Thank you very much for joining us. I think we've got a really great event ahead. My name is Alison Dougal, and I'm your chair for this event that is looking at inclusion and exclusion, the curriculum in special care dentistry. So thank you all very much for joining us, and thank you so much to our sponsor, Dentsply Sirona, for sponsoring this subject, because it's a subject that I think is not often chosen by sponsors. So I would really like to pay respect for their interest in this area. So I'm going to share my screen and just tell you a little bit about what's happening today. Let me while I'm doing this. So I am currently president of the IADH, which is an international association which is full of people who are interested in working towards better oral health for people with disabilities and disadvantages, working in communities, professional societies, universities, social service organizations. And this is a really good interdisciplinary forum, as is usual with special care dentistry, but it includes scientists, hygienists, dental nurses, speech and language therapists, dentists, both general and specialists, educators, and those people working with children and adults with disabilities throughout their whole life course. So I know there's a lot of people from a lot of countries out there. In IADH, we've got 8,500 members interested in people with disabilities working in 30 countries throughout the world. We've got a memorandum of understanding with FDI regarding the health and dental care of people with disabilities, and a really, really close working relationship for actually a long period of time with AD. And it's really that we're celebrating today, because again, with AD, we realize that for people with disabilities, the social determinants out there already create significant inequalities for people with disabilities. And then the way in which a society perceives disability adds additional effects. But wherever people live in the world, it appears that oral disease and oral problems still remain on the whole untreated amongst people with disabilities. And when treated, there are inequitable outcomes. Reduced access to appropriate care for people with disabilities has got many reasons, but service structure, skill set of staff, funding, facilities, and really importantly, attitudinal barriers within the profession, medical staff, and care providers. So my colleague, I work here at Trinity College in Dublin, and the professor who set up our Department of Special Care Dentistry right back in 2004 said it was no longer tenable within the Human Rights Act and the changing demography of population that new graduates can continue to qualify in ignorance of those for the wider community that they serve. This was a real exclusion. Despite disability legislation and the number of people with disabilities and disability rights movements making great grounds within dental treatment, still it was very unusual to have people with disabilities included in the patient flow or teaching, let alone departments. So we're here about the celebration of 10 years working with AD. IADH set up an education committee back in 2010, specifically tasked with looking at how education in special care dentistry, but education not throughout the whole curriculum, could start to reduce inequalities in oral health. So this was in 2012. A joint AD and IADH task force published this paper, which last year was actually recognized as one of the top 20 papers published in the area of dental research, because this was an area where people needed information. And what we said after doing a huge literature review, and the findings was that there needed to be sufficient primary and special care oral health care providers to provide quality care for those people requiring special care dentistry. We needed new graduates to qualify with the appropriate skills, behaviors, and attitudes. There needed to be accredited training, because this needed to be lifelong learning, But really importantly, special care dentistry was happening, but it wasn't working. We weren't actually impacting on the willingness of people to treat people with disabilities after they qualified. And the Convention for the Rights for People with Disabilities in countries that ratified the treaty meant that, we really had to up our game. So there was some evidence back in 2010 that undergraduate education improved the confidence and willingness to treat these patients, but there were inconclusive findings as to what sort of education. And what we saw in our group was that educators worldwide were suddenly being asked to provide curricula in SCD to teach in the schools to meet the profiles and competencies that were being put into the requirements. So we convened a panel of 43 experts in education in this field from 30 countries, and using a really intensive structured consensus process, a Delphi methodology, we went from first principles to look at what would be required by an undergraduate. After a lot of online activity, we met as a consensus group in that wonderful AD event that happened in Antalya, the fully inclusive one with the great parties in the evening. But a lot of hard work was done. And at the end of that period, we came up with a consensus on a minimum list of intended learning outcomes to equip undergraduates with the knowledge, attitudes, and skills. And we published that back in 2012. It's due for review at the moment, and we've spent the last 10 years really evaluating and looking at how people are getting on. Importantly was, if we're going to be inclusive, we needed these learning outcomes to be threaded throughout the whole curriculum, not just put in a silo for somewhere to be taught. That's not inclusion. So we actually mapped in 2014 all of those learning outcomes across the profile and competencies from AD, so that those learning outcomes would not be something separate, that the special care dentistry and disability was not somewhere else. Just an example, the communication outcomes meant that for the curriculum that already existed, that communication that looked at how to communicate with people with sensory or cognitive impairments, that skills were, that students were able to identify and modify communication, and they could use culturally sensitive and inclusive language. Sasha Scambler is going to talk a little bit about language after we speak. That was then, over the last 10 years, the curriculum has been translated into, I think, about 12 or 13 languages. There are problems in introducing the curriculum, and we know that that has included time for the study, but mostly the lack of academic departments or expertise for people within departments to teach this subject. We also realized that many students and staff in dental hospitals had had little or no exposure to people with disability in their lives. And quite frankly, they were scared, and scared means people keep away. So within the curriculum, we needed to find strategies and design environments to help the students ease them so they can learn on that. We wouldn't expect students to dip straight into taking out a distally impacted wisdom tooth. We'd put them through phantom head, we'd put them through simple extractions, we'd put them through mentored guidance, and the same with disability. So what you can see here in Argentina, they use incremental graded exposure with students doing play activities with people with disabilities. You can see in Saudi Arabia, they've got their students working in outreach programs. You can hear doing reading for people who are blind. Here you can see in Arizona, their students volunteer with Special Olympics to give them exposure. Here in Wales, you can see the students spending time in outreach, learning to be comfortable with wheelchairs and hoists. But what we found is that reflection and making meaning of that learning, thinking together and looking at personal beliefs, is what really starts to get students thinking that maybe this is something they can do, not that disability or disabled patients are for somebody else, angels, really good people to do. This is professionalism. This is part of their role. What sparked their interest was unanimously they provided care for patients, or there was disability in the family, or they encountered a mentor. It was never ever that they had a lecture about high arch palate in cerebral palsy or Down syndrome, for example. And I think this is one of the biggest things that we learned, that exposure to people with disabilities was going to be the thing that actually helped the best to help them with their confidence, for example, at that point. So I'm going to hand over now, because what happened was that during this 10 years, many of the universities have now set up departments and looked at really good learning opportunities. And I'm going to introduce you to Ron Kaczynski, who is working in NYU, and they have a brand new department which has students through it. And he's going to talk us about the students' learning environment, the students' learning experiences, and how they've worked with their students. So Ron, are you there? Could you share your screen for us? Thank you, and welcome, and thank you so much. We're really looking forward to hearing your presentation and the NYU experience. If you'd like to share your screen, I think.
I will. There we go.
Great. Okay. Fabulous.
Okay. Well, thank you, Allison. And I think we echo. It's very interesting to hear, from the worldwide perspective of the same things that we are, the same obstacles that we have in this community in the United States is really have been echoed in many of the things that you said. So a few years ago, our dean, Charles Bertolami, had seen a patient sitting in the waiting for an accessoride, which is a program that we have here to shuttle patients back and forth to the college. And he felt like we are not doing a very good job here and that we could do better. So Dean Bertolami put together a consortium of people. There were about 30 of us on the planning committee, and brought a group of people together to help to create a center in which we could offer respectful and dignified care to this patient population. So this is a little bit of, an embrace. And what we want to do here was to have our students, as you said before, I love that slide that said, stop. I think because that's what everybody normally did would be students would say that we can't treat you, we have to go to the operating room. And we really felt like we could do a better job in training our dental students to embrace this patient population instead of turning them away. So with that, we wanted to create a regional center of excellence for oral health care for people with disabilities, which would improve public health. And how would we do this? By providing a dental home for disabled patients on an ongoing basis in a way that translates into instead of admitting people into a hospital, that we could never hope to offer them the kind of care that they needed. And we wanted to provide faculty with particular interest and expertise in special needs dentistry, and provide expanded education in the treatment with people with disabilities for our students, so they would be able to enter the practice with the competence and confidence to provide comprehensive quality care for these individuals. And it's so amazing to see this transition that's occurring as the center opened. Unfortunately, as we'll see in some of the slides that we'll show, the pandemic has affected us as it has affected everyone else in the way that we are being able to offer care to this patient's population. But essentially the barriers to care that have occurred are people with physical, cognitive, and acquired disabilities have challenges in getting a checkup or cleaning. Some patients are fearful of light, sounds, or touch and may be unable to hold their head in place. And many dentists don't have the specialized skill set to provide effective care for this patient population. Many facilities are not adequately equipped to care for these patients. They weren't wheelchair accessible. Hospitals have long waiting lists in the United States to address the oral health needs of this patient population. And most hospital dental visits are emergencies with no follow-up, or patients will go and go to the OR and have, you know, all the care done in the operating room. And then unfortunately, we'll think that they don't have to follow up for years and years and years, and then the dentistry falls apart. And we wanted to change that premise and give people a dental home. And in 2012, a study of the Journal of American Dental Education found that people with disabilities have the worst oral health care than the general population. It's, again, something that was echoed by what Allison had spoken about before. And then there's an absence of a viable financial model that would make care for such individuals sustainable. A lot of, you know, insurance that people have in the States with disabilities, a lot of providers don't accept that. So here's some statistics for you. In the US population, there's an estimated 48.9 million people of a 325 million, or 19.4% have some form of a disability. 24.1 million of those have a severe disability. So the number is pretty staggering. In New York City alone, where the school is located, there's an estimated 950,000 people of our 8.5 million that have some form of a disability. And as you can see from the slide on the right, there are 99,000 people that use wheelchairs in New York City. So what happens when you have a lack of access to oral health care? Well, again, we have a recourse to a hospital operating room. Routinely, people have been waiting for 6 months or longer, followed by a protracted period of dental neglect, which can result in rehospitalization, you know, in 18 to 24 months. So we said we can do better and we must do better. And that's the adage that Dean Bertolami had gone by. I'm not going to spend the time showing this, but this was just, this video was shown about talking about access to care during COVID and the limited access to care that a patient had based upon with the pandemic. And this poor mom had gone months and months and months trying to secure care until they put this up on the news, on a local news station, and finally had a provider that volunteered to treat this patient population. And it's apropos to speak about how COVID has affected this patient population from receiving good dental care. We have in the United States something called Medicaid, and because of, we were considered non-essential initially when this happened. So we basically were shut down from providing dental care other than emergency extractions for almost 3 months here in the States, and unable to use the operating rooms at all. So most of the patients who are with the disabled community who were in group homes and other areas went back home. And the barriers to care that they seen were, a degree of dependence on others. These group homes and the normalcy that these patients had was no longer. They were relegated to going back to their homes. There were many reports that I'll share with you of parents that were, physically traumatized as a result of, their disabled children on the spectrum or whatever other disabilities that they had, who were taken away from the normalcy of their normal day. And that manifested itself in poor behavior, which we'll talk about. Some of the other barriers that we have are finances, as we spoke about before, the attitude of a care provider, having a lack of access to offices, modern parenting skills, stigmas, communication, social role valorization, culture, accountability, and behavior. So these are just some of the access. This is a true story, and this was something that happened when a mother of a 13-year-old just needed help, and she expected a crisis team to de-escalate the situation. But when this child ran away from the police, the officer opened fire on the patient and shot the patient, and shot the child. And this is just, this is a horrible story, obviously, but this is I have other stories whereby providers who actually were moms who I know in the profession who were physically hurt. One mother had her ribs broken because she couldn't find her son's flip-flop, and another mother had her child. She happens to be a dental hygienist, and her child wears a protective helmet, and he hit her so hard that she had ringing in the ears and had to be transported to the emergency room. This is I love this little snippet in this story, and it's a child who is pleading to be recognized as being normal and being and so to his parents, and he wishes that people don't have to be so mean and say not nice things. And I found that this is just resonates so much in the community of the disabled community today. It's so nice when somebody finds a good provider. And this is a story of a 25-year-old autistic male whose oral health journey began smoothly. He was treated by the same pediatric dentist as his sibling, so his dentist was familiar to him. But just before he graduated from high school, his mother learned that the family dentist was retiring. His mother was extremely worried about where she would take him in the future of his oral health care needs, but took the dentist referral. When Tina took Terrence to the new dentist and tried to make the staff aware of his needs, the staff wouldn't listen. And as a result, the visit was a disaster. It was more than 2 years before his mom found another provider. Thankfully, after a long search, she was able to find the right one. Now he looks forward to his dental appointments and smiles all the time. Tina hopes that the profession will eventually embrace the special needs population and feels it begins with a change in attitude. And again, in speaking to what Allison so eloquently delivered, the message is that, and the way to change attitudes is to be able to train dental students in dental school how to embrace and put their arms around this patient and this patient population, so that we have more providers that are able to treat this patient population. Here in the United States, for a number of years, it's been the pediatric dentists who have been relegated to treating these patients. And we are not always, I happen to be a pediatric dentist and a dental anesthesiologist, and I can't handle all the dental needs of the adult patient population all the time. And as a result of that, some of the good care that could be performed doesn't always happen. And I think by training dentists, young dentists, how to embrace this population, we can do a better job. Well, the barriers that people with ID face in the health system matter now more than ever with COVID-19. They can mean the difference between life and death. Healthcare professionals may not know how to communicate with people with ID about COVID-19 prevention and symptoms in ways that they understand. Hospitals are not set up to address the communication and sensory needs of people with ID, which I think is apropos given some of the future speakers. And I think that over 80% of healthcare professionals have never received training on how to treat people and do not necessarily know how to communicate with these people or feel comfortable treating them. So it's not just dentistry, it's medicine as well. And I think that we need to get together with our colleagues in medicine so that we can collaborate and provide good multidisciplinary care. So in addressing a major public health challenge and access to care, we talked about some of the physical disabilities that patients have, the cognitive disabilities that they may have, acquired and developmental. And you can see from the slide, there's a lot of different disabilities that people can have. So we wanted to here's some facts and figures about student experiences here at the center at NYU and what we created. We wanted to change the paradigm for the delivery of oral health care for people with disabilities. We wanted to provide a dental home for the disabled patients on an ongoing basis, and expanded dental education for our students to minimize their apprehension. And just as Allison said, just as we train, young pediatric dentists, about the basic fears that children have, I think that Allison was spot on in what she said about, dental students are afraid of the unknown and we're afraid of these patients. And if we can do a good job of teaching students to not be fearful of this patient population, I think we're hitting a home run. And we want to treat, a lot of these patients have complex comorbidities as well. And it's hard enough to train a dental student to treat a normal healthy patient. When you add a disability and then a complex comorbidity, it really takes it to another level. And I think it makes it even more difficult. The first patient was seen in the Oral Health Center on February 12th of 2019. This was a collaboration that, the 30 people turned into to 20, and with the cooperation, I want to thank Dentsply Sirona for sponsoring this today, and they worked so well with us in creating the center, in collaborating with a lot of the other companies as well. And the center would not be what it was had not been for the help that was offered to us through Dentsply Sirona. We had very small expansion. We had a small special care dentistry program here at the university before the center opened, and we treated about 3,000. We did about 3,000 patient visits per year, and that's a drop in the bucket compared to what we were doing prior to the pandemic. We were scheduling between 35 and 50 patients per day, so we were seeing an average of you can do the numbers, and it would be between 250 patients a week, which was a staggering number. Sorry about that. There was a wide array of patients with diagnosis and patients who obviously couldn't have dental care done previously. What I have provided, I think what we're doing here at the college, and what I speak to has really is what I like the most, is that we're able to perform multidisciplinary care here. And finally, this patient population doesn't have to be referred all over the college to have different treatment done. They are able to get all the multidisciplines have a presence here in the school. Patients don't have to transfer out of wheelchairs now. We have a wheelchair tilt that you'll see later, which was, again, through our friends at Dentsply Sirona. We were able to find a company in London who makes these chairs, and there were only 40 of them in the United States when we found them. I wish we had two. We outfitted just one room with one, and so we have so many patients in wheelchairs that the tilt is very helpful. So the patients love the fact that they don't have to transfer out of their chair. We have a tremendous number of autistic patients. We have a multi-sensory room, which we created. And being at NYU, there are many other schools associated with NYU. And Charles Berlami, our dean, recognizes the importance of collaboration and interdisciplinary collaboration within the colleges. And so he made some very great introductions to me of collaborators at the Tandon School of Engineering, the Steinhardt School of Occupational Therapy, and some of the other colleges within the university. And we were able to put together focus groups of parents and children and create things for the multisensory room that were placed in there and made some we put a special egg chair in there that was that has the room is you'll see in a few minutes about what it entails. And I just finished working with a master's thesis student at the School of Engineering to do a virtual reality app that patients will be able to go on their iPhones and take a virtual tour of the center prior to coming. And we're almost there. I wish I had this. He's just about there in creating it, and it's really very stunning. It's so nice to work with the other colleges and bring students together to collaborate to create some great things. We found that challenging moments have brought out the best in the faculty, staff, and the students. We are able to have specialty care providers every day of the week. We have a pediatric presence is represented here every day, so that anybody under the age of 14, we have pediatric residents rotating through and treating our young patients with disabilities. We have orthodontists. We have an endodontic resident on rotation once a week, because as you know, and you can well imagine that the biggest challenge that we would have was getting endodontics treated, these patients treated, and getting that, and having that, being able to offer that. We do have oral surgery. We have implant perio. We have oral medicine, oral facial pain, and prosthodontist faculty on the schedule. They're not up here every day, but they do come up at least once a week. We have a prosthodontic faculty on rotation who comes up once a week as well, and brings two prostho residents with him to do the more complex cases. We, as you will see, have two large sedation suites that we'll hope to get become operating rooms in the future. They are state of the art. We offer various sedation options: nitrous oxide, oral conscious sedation, IV sedation, and then hopefully we'll be doing more general anesthesia in the future. We were on the cusp of hiring an anesthesiologist, and unfortunately, because of the pandemic, we were unable to. Or there was been a hiring freeze in the university, but I have made the the dean and the administration aware of the fact of the need for this anesthesiologist to get them here, other than myself, because it's really, I can't administrate this clinic and run the center with that and do anesthesia at the same time. We have a multidisciplinary craniofacial team at NYU Langone Hospital. So we share patients with something called the MyFace organization. And that is, MyFace is made up of oral surgeons, plastic surgeons, orthodontists, and we have a craniofacial conference every month here, where those patients that we collaborate with from NYU Langone come here and are seen by the pediatric residents. The student experiences that occur here, we did have, I'm sorry for this, was full day, not A, but we have 12 dental honor students where fourth year honor students that would spend a full day a week here for the full year of their final year of their educational experience. Because we are limited to occupying only 50% of the building because of the pandemic, unfortunately, these honor students were unable to participate in the honors program this year. We have rotating fourth year dental students. Up until the pandemic, they were here for 6 weeks at a time. So they would spend a full 6 weeks here at the center treating patients in special health care with special needs. And so it was really a wonderful experience for them. We also have rotating deep dental third year dental students who were observers or recorded, and they were here for 3 weeks periods of time. And then we were doing some new rotation opportunities for dental assisting, hygiene, and nursing students, and having nursing students here as well. Unfortunately, again, because of the pandemic, all this came to a screeching halt last March 13th here at NYU. And, and there were multiple student organization collaborations with clubs and, special care dentistry clubs. And there's an organization called ADMD, which is a group here in the States that is made up of both medical and dental providers to come together to collaborate on multidisciplinary care. The center, as you can see from the pictures on the bottom, have, it's again, we've been established, and the media attention that we got when we opened was really, it's the first center in the nation. It's not the first center in the nation. There are other centers, but of its kind. We really took 8,000 square feet, and we made, I thought it would be very important to make 9 treatment rooms and we have 2 full operating room suites, which you can see at the bottom of the pages here. And as you can see on the one that I'm pointing to with the arrow, it's probably the only operating room in the United States that has a clear view on a beautiful day of the Empire State Building. So it's really an anesthesiologist's dream to work in that operating room. In that room, we have a video screen that has cameras and the lights, so that we can whatever we're doing in the operating room, we can show to students in conference rooms and utilize that for webinars and Zoom meetings, et cetera. So there's a lot of times now that we'll be actually doing cases, and we'll be able to broadcast live to other students who are learning remotely. Our treatment rooms have the ability to change the colors of the lights. We have large treatment rooms that are 275 square feet each, so that students can come in with whoever they need to bring with them. I mean, the patients can come with their whoever they need to bring. Unfortunately, again, we're unable to bring a lot of people into these rooms right now, and we can only occupy 50% of them. But some of the other media outlets that we were spoken on were some of the major news outlets as well. And we had a lot of attention in media that was drawn to us, which has been it was really wonderful, because we had really gained the attention, the media attention. We really took the focus and put it where it really needed on getting these patients and the people with disabilities, giving them a voice and giving them the ability. I had been invited all over the United States to really speak on it, and had gone was supposed to go pretty much to a lot of places all over the world this year. Again, all came to a screeching halt. And speaking of the NYU experience and how we manifested bringing this educational experience to multiple different people. Now, we did not begin to see patients again here at the center until July 31st. And that was not bringing in, the students did not come back into school until September. So when we only had 3 or 4 chairs available, and out of my 9, and all the care that was being provided from July 31st until September was faculty driven. So we actually had myself and some of our other faculty members that are here in the center treating patients. We had post-grad pediatrics patients, students helping to treat some of the pediatric patients as well. But we only had postdoc students here initially. We didn't have undergrads that didn't come back until September. Now we have 10 fourth-year dental students who pair up and occupy 5 chairs out of our 9. We had no D3 students and third-year dental students or honor students as of yet. Some of the different organizations, this is showcasing some of speaking to health and equity for people with disabilities in the COVID era. Some of the distinctive features of the center that we spoke to is that we have 2 fully equipped sedation suites, which you saw pictures of, and you'll see again in the videos that will ensue, and that provide both inhalational and intravenous anesthesia under the supervision of myself and hopefully another anesthesiologist. And this will obviate the need to send patients to hospitals where there are long waiting lists, and that we can provide all that good care for them here. We have operatories that can accommodate wheelchairs, and we do have consult rooms which have for consultation with an interprofessional healthcare team, so that we can have everybody working up here at the same time. We have myself as the director. I had 2 nurses and a social worker. I don't have those people anymore. One of the nurses unfortunately resigned pre-COVID, and the social worker also resigned. So we don't have a nurse right now. We have special service representatives. I have a clinic manager who runs the clinic, and I have a patient care coordinator who works with the teams of people to help coordinate care, multidisciplinary care. We have a wonderful multi-sensory room that you'll see that has the ability we can administer medications in there. We can even have dental students do exams with a patient. We have weighted blankets and other things in the room, so that patients, if they need to, they can do an exam with an iPhone light and just get a decent view of what may be going on if we can't get the patient actually to the clinic. Yes.
Ron, I'm going to have to say in a couple of minutes we're going to have to move on. It's fascinating. It's such a shame. Maybe we can deal with some of this in the questions.
No problem. So just let me know when and you have to stop us. Tell me when.
Anytime now.
Okay, fine. I'm sorry.
I'm sorry.
No worries.
No worries. It's fascinating. It's such a shame. We've got such a lot to pack in.
We almost ended it. Also, thank you so much for your attention, and presentations are there. So maybe we can share the presentations and some of the people, if they want to watch it at home, they can watch the videos at home. Thank you, Alison. I appreciate it. Thank you, everybody.
Okay, fantastic. And I think it's great for people to see, and I hope people have got lots of questions. I know there's one coming from Canada. I'm going to leave that for the panel at the end because I'm going to ask that same question to everybody. So could you stop sharing your screen? I'm very jealous of your unit. I have to say, I've been teaching special care dentistry for about 20 years. And I must say, you've got the dream facility. So congratulations on whatever you needed to do to get that operational, because advocating and going through the barriers is huge. So I really take my hat off you as clinical director for what's your secret? How did you manage that? For those people in facilities all over the world, what's your golden tip for having managed to integrate something like that into the NYU?
That's a great question, Alison, and I think that the tip was having a dean that had the foresight to see the importance of giving dental students this educational opportunity. And I think through his hard work and effort, the dean was able to spend the funds and to make the administration understand the importance of bringing to light how desperately important it is to train dental students to be able to embrace this population.
Do you know how we had exactly the same in Dublin, and I think probably that's something that we've got in common. Our dean was also a special care dentist. So what this tells everybody out there is, if you need to really want to do inclusion, you've got to head for dean and really embrace inclusion, so that students are so that students are really do get the experiences and training they need to be able to provide care for those who need it most. So thank you very much. So that's your top tip. Get yourself a dean or vote for dean with inclusion. Thank you so much. I'm going to share my screen, and I'm going to move on to the next section. Let me see if this is going to work. And this is a little bit more unashamedly talking about the work of the IADH. I would like to say that, that you can imagine somebody with disability, the same disability, living just down the road or in the same city from Ron's facility, is going to probably over time have better oral health or be able to participate in dental visits so much better than somebody living in a different area, because disability is no doubt the interaction of people between the environment and the attitudes that they face. And so what we did in the IADH curriculum was try and make the International Classification of Functioning the core being of how we taught students, in that disability is continuous. It's not dichotomous. Disability is a matter of more or less, not yes and no. So that we teach the students that that really lots of things that are the things we're always taught about, the impairments, well, that can be overcome, but it's those barriers of that are imposed by the environment that we can overcome to provide care for most people with disabilities without a whole load of kit and a whole load of expertise. That actually people with disabilities have lots of resilience and ability to achieve care in primary care to a generalist practitioner if they overcome some of those environmental and especially those attitudinal barriers. And I think equality versus equity is so important when we're teaching students about what special care dentistry is. Equality, because that's at the heart of inclusion. What is inclusion? It means that everyone is seen in mainstream if possible, because that's the most accessible, it's the most acceptable to people with disabilities, and in most cases it's perfectly appropriate. However, if we give everybody the same, we can't kid ourselves that mainstream is going to suit everyone. People can only be mainstreamed if they have the support and help they need. If you look at equitable outcomes, you see that the guy in the center needs a little bit of help to see over the fence. The guy on the right needs a lot of help to achieve that same equitable outcome. And this is what special care dentistry is. We teach the students that, everybody has the ability to achieve or participate, but the amount of support they need is variable. And in most cases, we can move a lot of those barriers away and liberate people with disabilities so they don't have to go to a center that may be closed during COVID. They've actually got, a mainstream service that's just making reasonable adjustments. So what does inclusion mean? Inclusion means a wheelchair tilt in your local health care center, or for somebody who sees a lot of people, a lot older people with disabilities, for example. Inclusion includes reasonable adjustments. Just the same in this guy has some extra kit to help him do his swimming at the local swimming baths. This guy has some seating adjustments at his local healthcare center. Inclusion means being listened to, being valued. Inclusion means asking and assessing whether your patients with disabilities are understanding what you're saying. Are you listening to them? Are you really listening to them? And are you making a plan with them that is acceptable to them? So I think these are all the things that we can be teaching students, which are transferable to all of their patients. This is the spirit of patient-centered care that we learn so much about, of interdisciplinary working. Inclusion means students preparing social storybooks for their patients that they can do in their own clinic. You can see them using apps on their own phones. No fancy stuff here. This is something they can take to their own clinic afterwards. Inclusion also means accepting this is that students can include special care dentistry research in their research. We've got a great project here with students saying, how prepared are we? And quite right, they're saying, we're prepared to see some patients with disabilities, but we can't see all of them. They're too complex. So they need the centres like Ron's to support them. And we know that people are going to see more disabilities in students if they know they're supported. So how we are going to find out whether centres like Ron's, whether the methodologies we use need tools to measure those things that are difficult. It's easy to assess people's medical knowledge or all of this kind of stuff, but evaluating education interventions in special care dentistry and attitudes specifically is difficult. Again, via AD and IADH, we got together a task force and identified a number of tools that could be used to evaluate those kind of softer skills that are thought to be positive attributes of students: emotional intelligence, integrity, empathy, all those things. And moving along our timeline, in 2007, we as a research network published a toolbox of tools and tests to measure attitudes. The reason we did this was because we saw lots of research starting to come out, but people weren't using standardized tools. They weren't using tools that could be reproducible, for example. So we wanted to put forward a battery of tests that people would use, and we developed a specific tool to actually look at evaluating planned behavior, so that we could assess how people were acting now, how they were thinking. We knew they could tell us the right answers that would get them good marks in empathy scales. But this was a specific tool that came from psychology to look at how people might act in the future. So had we impacted on their intention to treat people with disabilities around scenarios with a battery of 16 questions saying, for example, would you provide care for this patient in this scenario? Would it be normal? Would it be scary? People who are important to you would expect you to treat this patient, looking at subjective norms, looking at their behavioral control and their control beliefs. I'm not confident I could treat this patient, or I am. So very, very specific tools that we developed. And I was delighted when we held our 50th anniversary research awards this year. AD always award and collaborate with us with our educational research, that a lot of those tools had been used in the education awards this year. So I'm very pleased to introduce to you two of the winners of our competitions this year. The first is from Spain, and this is, I'm going to just stop my screen here, and I'm going to ask Matthew Diniz to share his screen. This gentleman won first prize in our educational, we awarded two joint first prizes. We had fantastic standard. And Matthew is going to look about evaluating, because as educators, and especially with only limited time, we need to know if what we're doing is going to be useful. So Matthew Diniz works in the University of Santiago de Compostela in Spain, and he's going to talk about clinical training and its impact on the attitudes of undergraduates. So Matthew, thank you very much. Congratulations on your prize, and the floor is yours.
Good afternoon. Thank you very much for your kindly presentation and for the opportunity to participate in this session today. I'm not sure if I can go ahead. Okay, now. The present work was developed at the Special Care Dentistry Unit at the University of Santiago de Compostela, directed by Professor Pedro Diz. As mentioned before by our chair, the IADH had published a guidance to unify content in the curriculum, undergraduate and postgraduate curriculum in special care dentistry worldwide. However, even in the same country, like here in Spain, we can find huge differences in credits and contents between the Spanish dental schools. was also mentioned the difficulty in evaluate the impact of this curriculum content in attitudes and behavior of our dental students. So the objective of our study it was to evaluate how access to clinical practices in real-world scenarios affects the attitudes and behaviors of undergraduate students with respect to the dental care of individuals with special needs. For our study group was represented by 40 students of the 5th year of dental school here in Santiago. We applied the IADH tool in 3 different moments at T0 before the start of the academic year, T1 after the students received the theoretical training and 60 hours of practical training, and at T2 after receiving plus 120 practical hours of practical training. Here in our university, the practical training was organized at 3 levels, doing, helping, and seeing, based on the complexity of the special treatment, dental treatment required. For this study, we only used the questionnaire 3 and 4 that intend to evaluate attitudes and expected behavior. And 4 scenarios chosen was a patient with physical disability, a patient with schizophrenia, an elderly patient with Alzheimer's disease, and an immigrant who doesn't speak our language. I will briefly show some, I think, interesting results. For example, in this question, should patients with disability always be treated by specialist practitioners? We can see that after receive the 60 hours of practical training, the number of students that strongly agree increase, and after in the T2 moment, the number of students decrease. The same tendency we can see in this question when we asked, is more training needed to prepare dental practitioners to provide care for patients with a disability? And taking together all the results, because it's relative large questionnaires, we can conclude that limited practical training increases student reserves for treating certain patients with special needs, especially those with limited cooperation. And increasing the duration of the practical clinical training, the student self-sufficiency is increased in all of the planned scenarios. Thank you very much.
Thank you, Marcio. Could you stop sharing your screen? I've got some questions that I'd love to ask you as a fellow teacher in special care dentistry. At what point do you introduce clinical hands-on training to your undergraduates?
In the other disciplines in the 3rd year. And in the special care dentistry in the last year, the 5th year.
In the 5th year, I think that's got a lot in common, because I think this is a bit what we were talking about earlier, about needing to have perhaps exposure and to people with disabilities and do the attitudes training, whatever, and then put some clinical training on, because students are quite limited in their clinical in their experience. We've got around this in Dublin by doing things like oral hygiene instruction and simple clinical stuff, and we've especially found it's a very good way to teach students, for example, minimally invasive dentistry, which we've been doing for years, and the use in special care dentistry. So can I ask, what did you find? Why did you use the IADH tool? I'm delighted that you did, but why did you use it? There's lots out there. How did you find it, and why did you use it?
Yeah, we chose this tool because the reproducibility of the tool was evaluated and proved before by experts in different countries with a very different socio and cultural background, like UK and Malaysia. And I think one of the first advantages of this tool is because is this versatility, because you can adapt it not only to different social cultural backgrounds, but also you can adapt each scenario to different levels of complexity based on the clinical competence of the respondents.
Yeah, thank you. I'd just like to thank you for your work. It's great to see a brilliant researcher from an oral surgery and oral medicine background becoming interested in this field and doing such rigorous research. So if you'll join us on the panel later, I'm sure there'll be more questions for you. I'm now going to introduce our other winner from our educational session, and that is Dr. Maz Ahmed from Malaysia. And if you'd like to share your screen, Maz, Maz is going to talk about their experience in Malaysia about teaching communication training and how this impacts on dental students. So thank you very much. And again, Maz, congratulations on your win, and congratulations on the amazing work that you've done in Malaysia. I remember in Antalya 10 years ago, two people coming from the University of Malaya saying they were thinking of starting an undergraduate program. 10 years later, I know that they sent specialists off to Australia to be trained. I know they've set up not only an undergraduate program, but now the first postgraduate doctorate program, absolutely forging ahead. So I know you've been instrumental in that. So congratulations on that too. Like Ron, we've got to have these people leading this very strongly. So congratulations, and I'm really looking forward to hearing your presentation. The floor is yours.
Okay, thank you, Alison. Can everyone hear me? Yep. Okay.
Yes.
All right. So, okay. Thank you. Thank you to ADEE and IADH for allowing me this platform for me to share the research that I've done on my students and involving people with disabilities in Malaysia. So, okay, my name is Mas Ahmed from Malaysia, and today I'm going to present my research entitled Sign Language Communication Training, Impact on Dental Students' Empathy, Learning Experiences, and Attitudes towards People with Disability. So people with hearing and or speech impairments, or I will refer to HSI, demonstrated poor oral health status, high burden of oral diseases, and low dental attendance. Patients perceived that they face difficulty to communicate with the dental team, and dentists demonstrated lack of empathy and competence when managing patients with HSI. On the other hand, dental students cited lack of comfort, and they have inadequate clinical exposure and training at undergraduate level in managing these patients. In order to improve the quality of patient care, dental professionals need to learn an effective method to communicate with these patients. One of the ways is by learning sign language, which use have been previously associated with improved dental attendance, treatment provision, as well as patients' cooperation and attitudes in the dental chair. However, the impact of learning sign language on learners, in this case dental students, has not been thoroughly explored. This study was undertaken to evaluate the impact of training in sign language communication, or SLC, on dental students' empathy and attitudes towards people with disabilities, as well as to determine students' perception of the training program. 28 first-year dental students were randomly selected to participate in the program, developed by myself and deaf trainers. Participants answered the validated Toronto Empathy Questionnaire, or TEQ, and the Attitudes Towards Disabled Persons Survey, or ATDP, before and after the program. The program consisted of a 14-hour hands-on practical session delivered over 7 weeks, followed by a 3-hour visit to a deaf school where participants conduct activities in sign language. Students also wrote a reflective journal to note their learning experiences throughout the program. Quantitative data were analyzed via PET-T tests using SPSS, whereas qualitative data were analyzed via thematic analysis. Following the program, participants demonstrated a significant increase in total mean empathy score of the TEQ from 47.1 to 52.3. Participants also demonstrated a significant increase in individual mean scores for 9 out of 16 items of the TEQ. The 9 items with significant increase in mean empathy score related to feeling disturbed about other people's misfortune, making others feel better, feeling concerned, in tune, and sympathetic towards others, being not easily irritable, being interested with others' feelings, having the urge to help others, and feeling pitiful when others are being unfairly treated. In terms of attitudes, participants demonstrated a significant increase in ATDB mean score from 62.5 before the program to 68 after. Students perceived that the learning program enhanced their disability awareness. They are now more aware of the deaf culture and disability issues. It was noted that this knowledge would be valuable and applicable when they practice dentistry later. They also feel more enthusiastic towards helping people with disabilities to access quality oral health care while promoting their welfare and rights for inclusivity and equity. Students opine that the program helped them to acquire essential abilities such as communication skill, as they now feel more comfortable to interact with deaf patients. They also noted acquiring thinking and memorizing abilities through exercises that require them to remember the signs, understand the movements, and interpret the meanings. Students also learn about working in a team, which is essential for their training and future practice. Students express that they now have improved personal values and beliefs where they realize they need to feel humble, grateful, kind, and empathetic towards others. So this study found that the program is effective in improving students' empathy, which was previously reported to decline as they progress through their studies. The training has also resulted in improvement of students' personal values and beliefs, attitudes towards people with disabilities, and it enhanced their disability awareness. And these are important elements that contribute towards the values that define professionalism in dental practice. Okay, and these essential and value-added skills could contribute towards development of personal, educational, and professional enhancement, and this would subsequently determine one's survival and success during studies and career. So we would like to recommend the introduction of the sign language communication training program in undergraduate and postgraduate curriculum in special care dentistry, and collaboration with external organizations could help in developing such a program. So for future research, we would like to recommend a longitudinal study to measure the long-term impact of such a program on dental education and practice. To conclude, the sign language communication training program is effective in improving dental students' empathy and attitudes towards people with disability, while providing learning experiences that are beneficial in improving patient care and personal development. Thank you.
Thank you very much, Maz. Would you like to stop sharing your screen? And congratulations on your study. Empathy is so important, life skills, and also as a patient-centered clinician. Can I ask, what are you doing any other methods to work on or look at empathy in your students? I know you're Vice Dean, and again, we're getting here with the old Ronald's tip here that Maz has risen to Vice Dean, and I think, again, we've got a common thread, haven't we, coming here? So Maz, what else are you doing with your students to take forward their empathy assessments?
I actually came up with an innovative learning intervention called photo dentistry, where I use street photographs. And this work has been recently published in the Journal of Dental Education. So what we did is we took some photographs on the street of Kuala Lumpur with various teams, such as the garbage collector, the homeless, the beggar. So students are to interpret the photographs and use their critical thinking skills on how these images could relate to patient care. And again, it was found that there was a significant increase in the level of empathy following the activities. So you can read about my work, this work further in my publication in Journal of Dental Education. So yeah, it's if you're interested in arts and science. So it's this project actually integrates arts and science in dental education.
Yeah, I think that this really demonstrates how innovation in teaching. I know you were trained in your specialty of special care dentistry in Melbourne, and I remember reading about the art, the art that was used in medical education by Mina Borromeo, for example, in Melbourne, and it's amazing to see that passing through you and creating an innovative educator. So we have a question that's come from, I believe, Saudi Arabia. No, it's come from Dubai, from somebody from the Arabic Society of Disability and Oral Health. They're saying, beautiful research project, thank you. Where can they read more of your research? And are you going to publish this study?
Oh yeah, it's going to come up in the journal that the journal that I submitted with IADH. Yeah, it's going to be published. Is it next month?
It is, yes. So all of the winners of this year's research prizes for IADH, we did some in special care dentistry as well, all will received as a prize an extended abstract, 1,000 words in the journal Medicina Oral Pathologia. So I think that is coming out end of December, early January. And we're really pleased because that means that this research will be able to be found, listed and whatever. So Maz, congratulations. I'm going to ask you to join the panel afterwards. And again, fascinating research. I am going to now very swiftly move to our final presenter before our panel, and I'm very delighted in the spirit of special care dentistry and the fact that interdisciplinary research and sociology and psychology is so important in our field. Going to welcome Dr. Sasha Scambler from King's College in London, who's going to talk about terminology and how the terminology we use when we teach special care dentistry is so important, but how also it reflects society. And Sasha, if I can hand over to you, we're a few minutes late, but please take your time because I'm really looking forward to this presentation and I'm delighted that you were able to join us, and the floor is yours. Thank you. Do you want to unmute? Great.
Can you see my slides?
We can, yes.
Cool. Right, in that case, hello. My name's Sasha Scambler and I'm a reader in medical sociology at King's College London. And Alison asked me to talk about language. And so what I thought I would do is take you through a socio-historical whirlwind trip through language in relation to disability. So the title of my talk is From Victims to Heroes to Scroungers, Changes in the Public Perception of Disabled People. And the aim then is to chart changes in the language people use to talk about disability across time, with the proviso that language reflects and shapes attitudes. So what I want to do is show how language shapes treatment and why the need to focus on attitudes that Alison's talked about is so central to providing for all of the needs of disabled people. So I want to provide through my analysis a socio-historical account of othering and of exclusion, which ties in with the theme of this event. It's worth stating at this point that I'm not going to focus on dental treatment. In fact, I'm not going to focus on dentistry at all, and that's a deliberate decision, because for me, attitudes are far bigger than simply dentistry. We're all people, and we bring our attitudes from the social world around us into our professions. Before I want to start, I also want to say a quick word about my language choice. So there's a lot of debate about people first versus disability first language. And in this talk, I use disability first language, which is the language of preference for disability studies academics and for disability rights activists. And there are two reasons for this. First, we don't feel the need to ascribe personhood to other groups. It's assumed. So why would we need to assert that disabled people are people first and use the people first language that a lot of organisations, including the National Health Service, prefer? The second and more important point from my perspective is that person with disability ascribes the disability to the individual. It belongs to them, whilst disabled person focuses on a person who is being disabled by the society that they live in, placing barriers in their way. So for me, disabled people is preferable and fits better with the social model approach to thinking about disability. Can I also just apologise for the fact that the examples I'm giving are largely UK or European centric, but my suspicion is that many of the themes are relevant and recognisable in other areas too, albeit to different degrees and at different times. Although I'm going to focus predominantly on more recent times, it's worth having a quick glance back through history. And that brief glance tells you that negative language about disability is consistent and comes from many different sources across many different times and many different places. So this quote comes from the Old Testament of the Bible, from Leviticus 21, verses 16 to 20. And it states, "The Lord said to Moses, say to Aaron, for the generations to come, none of your descendants who has a defect may come near to offer the food of his God. No man who has any defect may come near, no man who is blind or lame, disfigured or deformed, no man with a crippled foot or hand, or who is a hunchback or a dwarf, or who has any eye defect, or who has festering or running sores or damaged testicles." A detailed list of people to be excluded. And what's clear from this is the othering of disabled people and the exclusion of them from, in this case, religious ceremonies. So in the Old Testament times, disability was often seen as a punishment for sin, a belief that continues in many places and amongst many cultures today, particularly in relation to conditions such as epilepsy. A brief look at different points in European and predominantly UK history shows then that although the terminology has changed, and perhaps at times it's less overtly negative, the message of difference, of othering and of separation are clear throughout. So in the late 16th century across Europe, madhouses and asylums were established to segregate those who were considered different from the rest of the population. And these institutes housed people with a vast array of disabilities and long-term conditions and provided little in the way of care, but acted as a way of separating them out from the rest of us. Many of these institutions also provided access to the general public who could pay to come and observe the people within. By the late 18th century, there had been a move towards medicalisation and the idea that medical interventions could be used to treat disabled people. Treatments, however, were often radical and without much in the way of scientific rationale. So whilst the institutions themselves improved and often morphed into kind of quasi-medical hospital-style establishments, or what we used to in the UK call long-stay hospitals, the processes of segregating and separating disabled people from the general population largely continued till the 1960s and 1970s. And this heralded the start of the independent living movement, which started in Scandinavia and spread to the UK and resulted in the move to the deinstitutionalisation of disabled people, moving them into community-based care settings. It's worth noting, though, that this came with a focus on normalisation, the idea that we needed to make disabled people normal, in quotes, so that they were able to integrate better. So even while we were advocating integration, there was still the rhetoric of othering. and making the abnormal more normal. And alongside this, there was a challenge from disability activists and academics against the medical model, promoting a social model approach. I'm not going to talk about that, but it's just worth noting that that's where that came in to the discussions. So what can be seen then is a move from viewing disabled people as oddities, to be feared or laughed at or pitied as tragic. And medicalisation can be seen to have heralded this move, largely, seeing disabled people as impaired and treatable with the aim of returning them to normality. What you've got here is a selection of images, which for me kind of epitomise this first type of exclusion. So two of the images that you've got are of charity collection boxes that could be found on the streets of the UK, one from the 1980s and one much more recent. So the charity box from the 1980s shows a sad looking girl with her head hanging down, clutching a teddy bear and looking tragic and pitiable while wearing a caliper on her leg. The message is clear: I'm pitiable, I need your money. The second is of a collection box which was more recently used, which reads on it, charity box for especially difficult children, by which they mean disabled children. And underscoring all of this is the othering of disabled people as different, as needing to be separated out from the rest of the population, as in need of charity and as being pitiable. The next big change can be illustrated through tabloid coverage of disability from 2000s onwards. So these are all headlines from a search of the Daily Mail, which is a UK tabloid newspaper, my favourite teaching tool. And I conducted this search in 2014. The photo was a picture illustrating one of these stories, and my search term was simply disability. I didn't put anything else in at all. So these headlines weren't picked out. I took them all from the first page of results when I looked up disability in the Daily Mail. And the theme's obvious. The theme is fraud, it's cheats, it's scroungers, it's disabled people gaming the system. And in the middle, you've got the picture of a man who's sitting on the sofa with a cigarette in one hand and a TV remote control in the other, who doesn't look like he has a disability, so clearly he must be gaming the system.
Sasha, I think you may have frozen. Has anybody else lost the sound for Sasha? Yeah.
Continues. But we've moved from seeing disabled people victim.
Sasha, I don't know if you can hear me, but we've lost your sound. She's gone. She'll be back. But in the meantime, I've got some great questions out there while we're waiting for Sasha to log on. We got a question from Yogesh Bulsara, who wanted to ask the panelists, how many clinical sessions on average does a dental student have attendance at a special care clinic during their undergrad program, whether it's observational or hands-on? He wants to ask everybody. So could we start with Marcio? Can you tell us how many hours, for example, your undergrads would have either observation or hands-on?
Okay. In our university, after 120 hours, it's about 30 sessions of 4 hours each. We tried that almost of these sessions be at the doing level. It depends of the complexity of the patients, and but we try that most of these sessions are of the doing level. Students treating patients directly.
Okay, Marcio, how do your students get credits? Do they get credits for the complexity, for example? How do they get value in their towards their final exams? Do they get any kind of extra value for complexity, or is it attendance only?
Yeah, in the continuing evaluation, we take into account the complexity of the treatments.
Okay.
Under,
Okay. Okay, great, thank you. Ron, can I ask you the same question? How do you evaluate we heard how many hours that your honours students do. How do you evaluate their learning experience in your unit? Because I'm fascinated how this is going to progress as they turn out into dentists. How do you evaluate their experience?
That's a great question. They're evaluated by the faculty that are actually working with them. So we have special care dentistry faculty that is administering their educational experience. So they evaluate the students at the end of their rotation, which is this year it's 4 weeks, four full weeks.
Okay. Maz, how many hours would your undergraduates get, including patients with exclusion, who are socially excluded or whatever? How many hours do they do, observation and clinical?
Okay, they will have about 10 hours of lecture, 10 hours of hands-on clinical practice in the special care clinic, specialist clinic, and another 5 hours of community engagement project where they visit a special education school or center to provide activities. So in terms of assessment, so we have like a rubrics, which we give them different marks for like communication, treatment planning, behavioral guidance, and also a report out of their community engagement project. And also there will be at least an exam question, OSCE, where they're supposed to demonstrate oral hygiene instruction for a blind patient, for example. So yeah, that's how we do our assessment.
Yeah. So, and I can see those skills would be transferable across. From my perspective in Trinity, we don't do that much clinical hands-on. There would be people who have disabilities who patients would see as part of their general dentistry, but they spend 4 sessions on the special care dentistry clinic. They spend 4 outreach placements visiting government clinics in their 3rd year. We put a lot of store by their very, very interactive and student-centered learning. We have people with disabilities who come in and talk to our students so they can look at their life, and we have people with Down syndrome who lecture to our students. They would do communication workshops, toothbrushing workshops, and we do a lot of assessed reflective work, reflective log diaries, where the students have to, so on top of that, and questions in 3rd year and 5th year. So less physical clinical work, but a lot of assessment, and you can fail in Trinity if you don't pass your special care dentistry module. And I think that's really important because sadly we know assessment drives learning. So we have to make sure that this is an accessible situation. Oh, Dr. Scambler is back. Sasha, would you like to share your screen and come back to where you were, which was in the middle of the Daily Mail with a guy lying on the sofa, who evidently could never have any kind of social or emotional disability. But let's go back. Thank you.
Thank you. Sorry about that. I think that's Brexit Britain in practice. So, tabloid media coverage of disability. Carried out by Glasgow University, as I was saying, in 2012. And they looked at media coverage of disability in the first decade of the 2000s. And what they found was a significant increase in reports with a focus on disabled people, and that these reports had increasingly political slants to them. They also found a decrease in articles which were sympathetic to disabled people, and that in particular articles which focused on mental health or hidden disabilities were particularly unsympathetic. So during this period, articles focusing on benefit fraud almost doubled, along with an increase in articles focusing on the burden of disability, not to disabled people themselves, but to everybody else. And articles which looked at the political and social context in which disabled people were living, looking at things like poverty rates or low educational achievement or lack of service provision and so forth, were very rare. To find out the impacts of this coverage, the research team carried out a series of focus groups with members of the public. And what they found was that the public believed, unsurprisingly, that instances of fraud were actually much higher than they were. They believed that 70% of people claiming disability benefits were claiming falsely, where the government's actual figures for 2014 was 0.5%. Looking at the papers, they also found that there was a significant increase in the use of pejorative language, with almost 1 in 5 articles containing terms like scrounger or cheat or skiver. And the results of this coverage on disabled people were looked at, and they found that disabled people were feeling increasingly threatened, unsurprisingly. And just to note that disabled people were being labelled as scroungers and cheats in the context where research by Scope showed that disabled people apply for 60% more jobs before being hired than non-disabled people. And in the context of research by the Leonard Cheshire Foundation, which found that nearly a quarter of all employers admit that they're less likely to employ a disabled person even where they have the same skills as their non-disabled co-applicants. So the context is hugely important, and yet it's missing from many of these articles. And that's only part of the picture. In 2012, the World Health Organization commissioned the first study to look specifically at disability hate crime, conducted by Tom Shakespeare, a disability studies academic. And the study found that disabled adults are 50% more likely to be victims of violent crime. That adults with mental health issues in particular are 4 times more likely to be the victims, and disabled children are 57% more likely to be bullied or abused. They found that children with learning difficulties are more than 4 times more likely to be bullied, and that people with mental health problems are 10 times more likely to be the victims of hate crime. Again, this was followed by a study focusing on the attitudes of the public, which found that 2/3 of the British public feel uncomfortable talking to disabled people. And over 1/3 of them think that disabled people aren't as productive as everyone else. And over 80%, 85% of the British public believe that disabled people face prejudice, having said that they don't like talking to them, they don't think they're very productive. And 1/5 of 18 to 34-year-olds admit that they've actually avoided talking to disabled people because they're not sure how to communicate with them, which again picks up on the previous presentation. And perhaps unsurprisingly, 1/4 of disabled people themselves have experienced attitudes or behaviours where other people have expected less of them. So the language, the coverage, the perceptions can be seen to have a clear knock-on effect on both attitudes and on treatment, resulting in negative attitudes from the public, from employers, and resulting in a growth in hate crimes. The final thing to note here is a report by the United Nations Committee on the Rights of Disabled Persons that was published in 2016, following an unprecedented investigation into 5 years of austerity cuts by the UK government. The results of the investigation found that the UK reforms to welfare have led to grave and systematic violations of disability rights. The inquiry focused on any changes which might impact disproportionately on enjoyment by persons with disabilities of their rights to live independently and to be included in the community, to an adequate standard of living and social protection, and to work and employment. And from the perspective of this talk, the other key finding was that the report said that disabled people were regularly portrayed negatively as dependent or making a living out of benefits, as committing fraud, as benefit claimants, as being lazy or putting a burden on taxpayers. And those are the words of the report itself. So the committee made a clear, explicit link between the way disabled people are being portrayed, the government welfare reforms, and a grave and systematic violation of disability rights. So the othering continues, and we move on again from cheats and fraudsters to Paralympic heroes. So juxtaposed with the coverage from the tabloids of cheats and scroungers, the Paralympics in London 2012 were heralded as championing new attitudes towards disability in the UK. Then Prime Minister David Cameron said that These games and their coverage would inspire a lot of people and change people's views on disability. And similarly, the press coverage of the Paralympics extolled the superhuman abilities of the athletes. The British public seemed to follow suit, and 2.7 million tickets were sold. Globally, this was the most tickets ever sold for the Paralympics, with most events being a sellout. There were 500 hours of live coverage, and there was national pride in the achievements of Team GP Paralympic athletes. Oscar Pistorius, ironically now, the South African runner, became the unofficial Paralympic poster boy. He took part in the ordinary Olympics too, qualifying for the semi-final of the 400 metres. And he won the gold medal in the same event in the Paralympic T44 category. Here was surely proof of the breaking barriers between us and them. For a time, the media was full of discussions of impairment and disability, and there was commentary shows, mainly featuring and presented by disabled athletes, with plenty of risque chat challenging traditional views of disabled people as being unattractive or asexual. The focus was on inclusion, not exclusion, and the clear message was that they are just like us. But beneath the surface, has anything really changed? Probably not. So the Paralympics may have changed attitudes to and visibility of disability for a couple of weeks, but it's done little to change the lot of disabled people in the UK. And many disabled activists would argue that the coverage that was provided, while extensive, still had a focus on difference and othering. So if you look at these images from the Paralympics, and these come from both 2012 and 2016, what you see on the face of it are positive images of athletes. But if you look more closely, they often draw attention to disability, particularly if you look at the words used. More than sport. Why is it more than sport? Well, because these are disabled athletes who have overcome the odds to compete, because they have legs that are missing or don't work, because they have prosthetic limbs. The tagline for Channel 4 was the superhumans. Is that a positive message? Well, if it's the same message that's used for the Olympic athletes, then yes. But no. The focus on the Olympic coverage for 2012 was different. Posters pictured people engaged in sport in front of key London landscapes. The focus was on sports in London, not special people doing sports. And it wasn't just the posters. Coverage of the Paralympic athletes talked about races and training regimes, but they also talked about how athletes overcame the odds despite their disabilities. Backstories were given about legs lost in accidents or through meningitis, about fighting back from illness or despair. Human interest stories about overcoming the adversity of being impaired rather than about the achievements of athletes. And here the othering is twofold. Look at these amazing people who are not like us, and look at the adversity they've overcome and the personal tragedy they've overcome to succeed. So how much of a game changer was the Paralympics? Well, it lauded the prowess of disabled athletes, who were indeed impressive. It also highlighted the positive impact of participation, which is ironic given the ongoing political assault against funding and services required to enable participation of most disabled people in our society. But I would suggest that the impact of the Paralympics has been fleeting. And like the Olympic flame, it was quickly extinguished. So my final example, COVID. Othering in a global pandemic. So the COVID-19 pandemic has changed the fabric of society, you could argue, and it's left many people wondering about the social, the political and the economic impact and the structures that are going to emerge after the pandemic is over. The pandemic has also revealed the fragility and inhumanity of the system that's come to characterise British society and many others around the world. So drawing on the work of disability researchers like Janice McLaughlin, Alice Butler-Walk and Caroline Hood, I just want to briefly illustrate the impact of COVID on language around disability and the rise of a discourse of disposability that's been and is being applied to certain bodies during the COVID-19 pandemic. Guidance from the Centre for Disease Control in Atlanta in the States states that, based on current available information and clinical expertise, older adults and people of any age who have serious underlying medical conditions might be at higher risk of severe illness from COVID-19. Based on what we know, those at high risk are people who are over 65, people who live in nursing homes or long-term care facilities, and people of all ages with underlying medical conditions. In addition, what they state is that adults with disabilities are 3 times more likely to have heart disease, stroke, diabetes, or cancer than adults without. So let's break this down. Underlying health conditions. This is not a neutral term. What this term does is it makes a distinction between those who shouldn't die and those whose deaths are maybe of less concern. It's another way of othering disabled people. Butler, Walk and Hood argue that the othering in the discussion around COVID implies that bodies marked by underlying health conditions are inherently valueless and even potentially burdensome. The discourse of underlying health conditions raises key questions about the value applied to certain types of bodies that are branded by disability or age or other markers of what Goffman would call a spoiled identity. It also raises major questions about the philosophy of value and worth in a society that sees economic activity as the foundation for human value and an attendant right to life. So we see a discourse emerging where the value of lives defined by disability or underlying health conditions or vulnerability are pitted against those of other non-disabled members of society. Or we have what they call an economy versus lives of those with underlying conditions debate going on. The Frances Ryan quote here. Frances Ryan is a journalist who writes for The Guardian. And what she suggests is the idea that poverty, isolation, or even early death is somehow natural for disabled people is still worryingly prevalent amongst our discourse about COVID-19. And what was the UK government's response? Well, their response showed systematic discrimination against disabled people. Some of it was overt and some of it was just collateral damage of wider policies. So in their early reports that came out in February, as the threat of the pandemic was growing, the public was told that if critical care capacity were to be stretched to the limit, then the most vulnerable would be denied care. And by the most vulnerable, they meant older people and people with disabilities. When the UK went into lockdown, a whole range of things were brought out. So exercise was limited to 1 hour a day, but you weren't allowed to sit down while you were out exercising. So for people who couldn't be out for an hour without sitting down, they were essentially excluded from going out. They went to the extent that public benches were actually taped off so that people couldn't access them even if they needed to. We have no British Sign Language interpreters in our briefings on COVID, despite the National Deaf Children's Society, the RNID and various other people campaigning for that. The government said that the room was too small so we couldn't put BSL interpreters in. And this lack of consideration from government filters into social interactions. So it limits or it reduces the ability of disabled people to participate in social spaces. And it validates existing dynamics of policing disability and different embodiment in public spaces. So individuals with underlying health conditions now find themselves on the cusp of being overtly discriminated against for being vulnerable. So as McLaughlin argues, disabled people are routinely excluded from social life through words and through actions. And the dominance of individualism leads to justifications that disabled people and those with chronic conditions should be allowed in the public sphere only if they're economically productive. This retains the ableist hierarchy, and disabled people remain excludable. And that's my final slide. So what does this analysis tell us? It tells us that disabled people are always excludable. If you think back through the examples I've given, they're excludable from religious worship and from communion. They're excludable from the very communities and families that they were born into. They're excludable from economic and social participation in society, from the identity solely as athletes in the sports that they compete in, and from the right to have their lives seen as important, to the extent that treatment can actually be refused. So the times change, the means of exclusion change, the language focus changes, but the othering remains. But I do want to end on a positive note. There are many improvements in the care and treatment of disabled people, and there have been huge advances in access to quality general and dental care. So we're moving in the right direction. But it pays to be aware of and to challenge assumptions as and when we see them around us, or maybe more importantly, when we recognise them in ourselves. So attitudes and assumptions for me are the biggest barrier that disabled people face. And in the words of Hughes and Patterson, any barrier is a potent reminder that disabled people are always excludable, as inclusion is always conditional on someone else's perception of who belongs where. Thank you. Sorry about the catastrophic Wi-Fi event. You're muted, Alison.
There we go. Sasha, if you can stop sharing your screen. Wonderful and wonderfully thought-provoking. And I think that's the best thing we can do with our students. We can make them think. We can make them think about their own attitudes, and they can verbalize them, and we can have these conversations. And I think that certainly during COVID for us, when we've been teaching online, having time for these big discussions with students, making them think about that big old chest that you can't see people with disabilities in general practice because they take too much time, or there's too much money that is required, is such a big misnomer compared to, for example, people are willing to speak to the parent of a child for ages about whether someone needs orthodontics. But if it's someone with a disability who needs a bit longer, then that's somehow wrong. But I remember Clive Friedman from Canada saying that we need to teach students that this isn't charity, that certainly in most cases this is something that should be equitable, and in fact in many cultures is payable, so students can get paid in general practice for doing the work. It's not a charity situation. So thank you so much. You really for me highlighted the hierarchy of disability, that, you know, and I think that's why Marcio's talk was so interesting, because his scenarios looked at different types of people with disability, not the big pushers, the autism and Down syndrome, but included people with psychiatric disorders and people, you know, for whom English isn't their first language. And so I love the fact that IADH disability or special care dentistry is for those people whose social, physical, medical, emotional, behavioral, cognitive impairment impacts on their ability to maintain oral health. But I think we've had a fascinating discussion, and I think that Sasha's made us all think, and it's so important to look at these things and get these conversations going. We've got a couple of questions, and then we'll have to leave off. It says somebody is Ron wanting to know about the business model for your center in NYU. Can you share that?
The business model, meaning, I wish I can elaborate on what you mean by the business model.
Yeah, I think that means how are you funded for such spectacular wonderfulness?
So, thank you for it. Now I understand. So, that we had them because we're so tuition based here at the college, and we're so large. That we had, you know, every year the dean will look to a project. So we had to spend our own money. So it was the project ended up costing us almost $13 million. So we had to use our own money for this, and the dean at that time has to go to the administration and ask if we can goes to the president of the University of NYU and ask if we can spend the money. So it was essentially our own profits that we utilized to create the center. Yeah.
Okay. Thank you. Thank you. We've got something from Barry Quinn, who's asking all panelists. We need to clarify for our students and colleagues the correct languages. Some use disabilities, some use special needs, some use specially abled, super determined, you know, all these kind of the kind of stuff. What's your comment about that, Sasha? I know the superhero thing, and I don't feel comfortable with, you know, specially abled or whatever. But what about yourself? It's a very historical thing, isn't it? How do we encourage people not to be embarrassed about talking with disability without shutting them down the minute they say the wrong term? This is a big one for students. Yeah.
It's a big one for students. It's also a big one for staff, I think. And it's culturally different as well. So people use different terms in different places too. Yeah. My suggestion would be ask people. That's the easiest thing to do. Yeah. So if we want to make sure, the most important thing for me is that we get the terms right for the patients. And we do that by asking them how they want to be referred to.
Yeah. What do you think, Maz? It's the old special needs, special care debate. From my position, I don't care what anything's called, as long as it's holistic, patient-centered, personalized precision dentistry, which reduces barriers and you know, isn't across the board. But Maz, have you got any particular tips for how you teach terminology and language to your students?
Yeah, it's a tough one there, because even in Malaysia, we use different terms for different occasion. For example, our act and legislation use the term disability. In healthcare, we say special needs. And when I do my talk or lectures, I either use special needs or different abilities. So I suppose I need to see who I'm speaking to, so not to suit myself with the environment. But yeah, it's a tough one there. But we use the term special needs and disability when it comes to healthcare. Yeah.
Marcio, any tips as somebody for whom English is not your first language? This is often difficult for people for whom English is not their first language to get the cultural right. Any tips that I know you're Brazilian by birth and moved to Spain 15 years ago. Is that right?
Sorry, can you repeat?
I know you're Brazilian. I know you're Brazilian by birth, and I know it's difficult for people for whom English is not their first language to sometimes know which is the culturally acceptable term for that other place that you're living in. Any tips or any comments?
Yeah, I agree that we maybe in different occasions, it depends of the people that we are talking.
Yeah.
Here in Spain, we use the term special needs patients. In some occasions, persons with disabilities.
Yeah. For me, I think I don't know about you, but for me, there's only really one no-no, and that's the R word. I think so many people with disabilities do not like the word retarded, that we really have to join together and say, you know, although it's appeared for so long, and especially in research and still is in, you know, coding, I think mentally retarded is something that we're all trying to move away from. But whether it's intellectual disability, whether it's ID, whether it's learning disability, I think there's really no true. But I think that my personal is when patients come to me and say, I've got a case of Treacher syndrome, or I've got a case of Downs here. I don't like people being called a case. I think this is a person living with diabetes, or a person with a diagnosis of diabetes, or somebody who, but I think I've got a case of diabetes is the thing that I feel uncomfortable. That really means that we're not seeing the person, we're seeing. So that's my no-no. I think we all have our personal no-nos. Ron, have you got a personal thing that upsets you that you like to correct?
I think exactly as you said, Alison, I think that the R word is something that I don't like being utilized, and I try to discourage students. You know, the term, people like this term here in New York, and then the capital ability has been utilized a lot, and people have been, you know, gravitating towards utilizing that word.
Okay. We've got a hold up. I know Dennis Murphy from AD will be thrashing me. We've got one more question from Oman, and they're saying the challenge in Oman is getting enough clinical exposure for our undergrads. What's our advice other than changing the dean? I hope your dean's not listening, Nadia Al-Kindi from Oman. Any advice for moving things forward? Maz, any advice for increasing the likely exposure?
You need to go out. You need to go out and look for your patients. If you were to wait for your patients to come to you, you have to be very, very lucky. So a lot of extramural mobile dental clinic activities, voluntary CSR that we do to expose our students.
My own tip, Nadia, is that to work in pairs, that students get confidence from each other, so two students can have an experience at the same time. I think it's just slowly. I think as certainly the move towards interdisciplinary care and things, then I think that special care patients or patients with special healthcare needs can offer lots of things in one learning experience: medicine and surgery, communication, ethics, law. So I think that if patients can be seen as offering lots of advantages within the curriculum, then we can perhaps get students who are given more curriculum time. When curriculum changes, that's the time. If a curriculum is being looked at, is being under review, that's the time to get in and restructure. What about you, Marcio? Any tips for getting? You've got huge amounts of clinical time. That it looks fantastic in Santiago. How can Nadia get more clinical time in Oman? Any tips?
I don't know. I think because our unit is working much time with this kind of patient, and now is a reference center. So we have a lot of patients for all parts of Galicia, our community. So we have a wait list to treat all of these patients.
I think, and then we'll go to Ron, I think that the establishment of an academic department is key for the research, for the expertise, and then slowly build the clinics like Ron has done, or like that. I think that the academic specialty to lead the teaching, so it's not piecemeal, so it can be coordinated through the years. I think it takes time. Nadia, I know that relatively your course is young and you've done amazingly to establish it in Oman. So I think patience and resilience and tenacity and keep going. Nothing is, this is a long race. So just straightforward. We've got we've got some nice comments coming in before it, but we've got from Steve Perlman, who's the Director of Special Olympics, Special Smiles. We have a memorandum of understanding between IADH and Special Olympics, and I know a lot of our members have great success in their students volunteering for Special Olympics, not only to see the positive roles of the sportsmen and sportswomen, but also looking at the abilities, and I think this is a great learning experience for students when we know that they are scared to be around people with disabilities. But it's a good way of them learning the language. It's a good way of them seeing positive images. So you're very welcome, Steve. And I see Alan Wong's here as well. Clive Friedman is here. He's got one last thing. He wants to ask who used the IADH curriculum to design their programs. Can we have a show of hands? Yeah, for me. We did. We used the IADH curriculum, and we used it to design our postgraduate curriculum as well. So we haven't got time, but hopefully this is one of our many webinars, Clive, coming forward. But I'd like to finish the session to say thank you so much for your participation. Thank you for such a large audience and such great questions. Please consider visiting our website and AD website. Lots of stuff going on in special care and education. But let's not make this about specialists in special care. Let's make this inclusive. Let's make this everyone's business, not just for the special teachers or the special students. I think that's my take-home message. So universal access and inclusive access to healthcare. Thank you so much for listening. And I do believe this will be recorded so people can watch back if they want to take notes and things. But okay, and I think we'll leave it there.
Thank you.
Thank you to our sponsor. I must say thank you to our sponsor. Okay.